Good afternoon. We are the Urgent Wellness team. Urgent Wellness is a new social enterprise that will improve healthcare outcomes and lower healthcare costs for vulnerable populations. Think of a minute clinic, but placed in a homeless shelter and a Section 8 housing project. I'm Freya Spielberg. I'm a family medicine physician and a health service innovation researcher. And over the past 20 years, I've done many projects where I've shown that you can improve health outcomes and lower costs, but every time the grant ends, the project ends. So now I'm starting a social enterprise to be able to bring these effective interventions together to scale them up in a sustainable way and meet the needs of these vulnerable populations. And I brought together a stellar team to ensure success.
Hi, I'm Aubrey Villalobos. My background is in public health research and community health promotion, and I'll be overseeing operations.
Good afternoon. I'm Luigi LeBlanc with a background in health information technology. I serve as technical lead for the team with 15 years implementing integrated systems with a special focus in telehealth.
Hi there, my name is John Barabino on the business side. My background is in Silicon Valley. I was at 4 high-growth companies, including Google, where I built and ran the business development team.
So Urgent Wellness will provide an innovative healthcare solution for Medicaid managed care organizations who are now required to meet health quality goals in order to get full payments. And what they have to do is decrease unnecessary ER admissions. They have to decrease preventable hospitalizations, and they've got to decrease 30-day hospital readmissions. We know the problem. In DC and around the country, 37% of emergency room visits actually are not necessary. They don't require emergency care. That results in $4.4 billion of avoidable health care costs annually. And more importantly, when someone goes to the ER to get care, they don't get their chronic disease needs met or their preventive care needs met. And so the health outcomes get worse and worse. Now we're in a new period of healthcare financing where pay for performance is gaining traction. And when companies don't get paid, if they don't have good health outcomes, this opens up an opportunity for organizations like ours to be able to help them improve their health outcomes while lowering healthcare costs. We did more than 50 interviews in preparation for creating and designing this business. John is one individual who we met who actually led us to a homeless shelter where he lives, where we will have one of our first sites. He has diabetes, hypertension, schizophrenia. He's not in primary care. He goes to the ER once a month, can't really navigate the community clinic system, and he would very much like to have urgent wellness services at the shelter. There are 200,000 people on Medicaid in DC alone. About 40,000 of them are high utilizers like John. When they're mobile clinics in kind of care deserts, such as Ward 7 and Ward 8, there are long lines of people to access care, but they're very limited mobile health services. We know why people go to the ER. They want free health care. They want to be able to walk in because it's very difficult navigating appointments. It needs to be convenient. Also, the environment needs to be welcoming, and the ER has really evolved as a place where vulnerable populations are comfortable, and that's not true in all clinics. But what's important and what we need to do is integrate acute care with preventive care and chronic disease management. We also talk to managed care organizations. We know that they will be penalized $9 million in the next year if they don't decrease by 5% avoidable low acuity ER visits, preventable admissions, and 30-day readmissions. And we know how to help them. So what we're going to do to decrease avoidable acute ER visits, we are going to place acute care telemedicine in homeless shelters and housing projects. We already know at the homeless shelter that we went to, they have 3 to 9 911 calls a night, half of which they said don't really require ER visits, but they have no other option. To decrease preventable admissions, we are going to pair that with community health workers that provide chronic disease management support. They will also, through our IT system, be notified when their clients are in the hospital so that they can connect with them and provide post-discharge support, which will keep them out of the hospital.
The good news is, for the past 2 years, under Freya's leadership, we've laid the foundation for health data exchange and for care coordination of high-risk populations in the district. We've put in funding to lay an infrastructure that allows safety net clinics in the district to connect with all the hospitals in the district, leveraging the health information exchange so that data can flow. In addition, we built a patient engagement portal, which can be accessible via a person's mobile application or a portable computing, so that they can register, they can learn, they can consent into the program, complete assessments, and also receive interactive counseling with a community health worker and a care coordinator. We then licensed a care management platform, a population health management platform, that allows our care team to engage with these high-risk beneficiaries that are enrolled so that we can be alerted when they've left and have left the hospital, and we can also reach them preemptively to prevent a rehospitalization, and most importantly, get the analytics so that we can report outcomes. So throughout the program, we enrolled 4,000 beneficiaries, and of those 4,000 beneficiaries, what we've reported and the outcomes have shown that we've increased knowledge with all 4,000 of them. Within that group of 10% that were detected to be about 400 that were detected to be HIV/AIDS positive, within that group, we reduced their viral load levels to undetectable rates. We then looked at some preliminary data analysis of a subpopulation, subsample of about 80 of those participants that were enrolled in care management. And what we have, the results have shown that we've decreased hospitalization by 26% and decreased ER visits by 17%. But most importantly, and I think what we're most proud of, is that we've been able to, from patient satisfaction surveys, have a very high retention rate and approval rate by the patients, where they would refer the program to their colleagues.
So what is this urgent wellness model? The community health workers are at the center of our model, and they will reach out to their neighbors, do baseline health assessments, bring them into care, and keep them in care. And we'll have on-site urgent wellness centers that will provide 4 key services, as we've already mentioned: mobile health education and counseling about prevention, chronic disease management and monitoring, delivery on-site of pharmacy medications and also health products and home tests to help people manage their chronic illnesses, and as we've mentioned, the telemedicine, all of this reducing unnecessary ER visits. What's unique about our model is the community health workers. We're going to approach communities and have them nominate natural helpers to come forward and be trained by Urgent Wellness, and then that will establish early trust and this cultural connection, which will allow us to maintain them in care and keep them well. This will give you an idea of what our urgent wellness centers could look like. This is a telemedicine cart that will provide a virtual visit to a provider through GW Telehealth, and this is what a pop-up semi-permanent kiosk on-site in the housing project or homeless center could potentially look like, though we have not started design and prototyping yet.
So our business model, to recap, is that we contract with the payer, the managed care organization, to provide the services via these urgent wellness centers that we locate in sites of great need. And in fact, currently we're working with AmeriHealth, which is the largest managed care organization in DC. They have over 100,000 members. We're actually working really closely with them. It's quite exciting. They've actually shared with us their sort of real data of their high-cost users. And we've identified the hotspots, which have both the highest percentage of ER use and also the poorest health outcomes. And based upon that, we've designed a sort of a 3-year intervention. In the first year, we would launch with 2 sites, growing to 20 in the third year. We'd have slightly under 300 clients in the first year across these 2 sites, growing to about 3,000 members in year 3, which again, this is sort of the 3% that's the hardest to reach, most vulnerable of their population, that currently they're not able to reach, and that's why they have the health outcomes that they need to fix. From a revenue perspective, the revenue to us would be $780,000 in the first year, growing to about $5 million by year 3. We make money 2 ways. One is we have a margin built into the clinical services that we bill for. And then second is increasingly there's a move towards pay-for-performance models. So we have a shared risk model where as we generate savings for the MCO, we get a cut of those savings. So you'll see both those 2 items here. And then this adds up to our total margin. So our margin from this contract, which is with just one payer, would be approximately $240,000 in the first year, growing to a little under $2 million in the third year. And again, this is from just one payer. We're focusing on AmeriHealth, and then we'll also talk to the other managed care organizations as well.
So the market opportunities, there's 3 managed care organizations in DC, as well as DC Healthcare Finance Fee-for-Service, and they cover 200,000 clients. Nationally, there's 70 million Medicaid clients. Of course, every state has Medicaid, and there's 55 million Medicare. You can imagine that once perfected, this is a model that actually would benefit any insurer. And even if ACA is eliminated or revised, there will still be a large Medicaid and Medicare population, and there will continue to be more and more pay-for-performance reimbursement that will really require a business like Urgent Wellness to help organizations meet their outcomes. So in summary, over the past 2 years, we built a very complex IT infrastructure. We determined the best methods for community engagement, and we completed our beta testing. Now we're ready to commercialize. We are asking in the first round for $1 million in startup cost. We'll actually be able to start billing right away. So we will recover our costs, probably break even within the first year, but certainly by the second year. And we plan to scale up rapidly with success. And I believe we have the team that will really ensure the success of Urgent Wellness.
Thank you.
Thank you.
So start with questions. What do you guys think is the biggest risk in this model?
You know, the biggest risk logistically really is the amount of time it takes to negotiate the contracts. You know, that will delay us. We, of course, are not going to be spending money until we actually get those contracts negotiated. I've been through this before. You know, it took us 9 months to get off the ground in the last iteration, and a considerable amount of time to create the contracts and do the hiring and training. So I think I kind of know what I'm getting into.
One, I think, really good sign there is in the meetings with the MCO, we proposed a timeline for the launch of the first 2 sites. And in the meeting, they were like, can you make it sooner? So I think when you've got the client asking you to like accelerate your timeline because they've got a real need, that's always a good sign.
So that being the biggest risk in the model, how, you talked a little bit about DC, but how much value is there in a customer relationship? Like, what's your ability to grow with these customers, like AmeriHealth and stuff?
So the beauty about an AmeriHealth is that there are multiple states.
Right.
So they're insuring many customers. Their headquarters is out of Philadelphia, but the district brings them the most revenue of all the states where they've got insured lives. So a model that works in the district will probably scale in other states. And there are also, there's MedStar, which plays on both sides regionally. So regionally, if we can demonstrate a viable solution, we can scale into Maryland as well. So we believe that if we are able to demonstrate, and when we're able to demonstrate that there's a workable model here, that other MCOs, particularly MCOs that have not yet adopted Medicaid expansion, will be looking for ways to address cost and quality.
2 really quick questions. John, on the MCO that had asked you to speed the timeline up, did they give you any indicators on verbal commitments or any confirmations that they would participate, assuming you could speed the timeline up?
Yeah, in fact, as soon as we're done with this meeting, we have to finish some slides. So they have an internal sponsorship process for projects, and the CEO and the medical director for DC, we're putting together the material for them to propose it to their senior management. And actually, that's our deliverable to do tonight after we finish this presentation. So,
Great, good news. Second quick question, I'm sorry, just real quick, is what did you, 2 years is a long time. It's a big investment on the passion side before you guys are getting to a place where you're scaling. What did you learn in the beta period?
A lot. So the IT system that we created, we haven't really had time to go into in depth, but it's unlike any that you'll see in the country. So we did a lot of work on designing patient-facing assessment and counseling tools for low literacy populations, including the creation of 100, plus videos for education, et cetera. So we kind of learned how to create media to address health literacy issues among the population. As far as community engagement, we learned quite a lot. We tried several different methods of embedding community health workers in hospitals, in clinics, in community-based organizations. Ultimately, the most successful method that we found in reaching people was doing what we're proposing here, which is bringing someone in from the housing project, training them up, having them be the conduit to bring their peers into the system, and that was much more cost-effective than any of the other models.
So why is it unlike anything that's out there?
Well, if you look...
What makes it unlike anything out there?
There are two big things that make it unlike anything out there. There are a lot of mobile health tools out there, right? Mm-hmm. But they're all, for the most part, disconnected from actually the clinical care delivery system. Mm-hmm. And so...
do you guys have a pipe into the
yes.
system?
So we've
Yes.
built...
That's proprietary. Do other people have access to those pipes?
Not proprietary, but what we've been able to do is to integrate our care management system with the patient engagement tool, with a health information exchange infrastructure that connects all the hospitals and is connecting all the clinics in this region. Not just in the district, but in Maryland and other places.
And once you have that, you have something that no one else has done, which is you have the ability to, wherever that patient goes in the clinics or hospitals in DC, if they have a lab value that's out of whack or a hospital or ER visit, immediately their community health worker gets pinged. They need to go out, reach that person, find them, bring them back into care. And that's really important. Having a closed loop system, right, to be able to reach and deliver care to those
I
populations.
think the telehealth is another really important component because in the previous project, that was a $16 million CMS funded innovation that went over 2 years, and that did not include telehealth. And so we're adding this acute care telehealth on site to avoid those unnecessary ER visits. And so blending care management with telehealth is not something that really anybody else is doing.
Yeah, and if you look at, there's an explosion of urgent care clinics, right, around the country, but all of them just do urgent care. So you are actually escalating health disparities and problems because people don't get their chronic disease and preventive care needs met. And so this is like the first system that I've seen that really addresses that head on.
So talk a little bit more about your human resources, because it sounds like the CHW is more an advocate and not a healthcare provider. And I don't know how you get one in a homeless shelter. And then in your quick numbers that you ran, I saw that in your pilot of 2, each one has half a nurse. And we all know in the United States, perhaps as everywhere, people are voracious in terms of wanting health care. So how are you doing all this for 284 people with one nurse?
Right.
And an uninformed in terms of, and an unlicensed in terms of medical practice CHW?
So the CHW is not your typical CHW. In the past project, we train them. They receive basic community health worker skills. They also receive education on using the IT systems that kind of guides everything that they do. They receive... Okay, and they receive motivational interviewing training, et cetera. What we found in the past project was that one nurse could supervise 4 to 5 community health workers. Remember, they're not, the community health workers are really assessing the needs, providing referrals, linking them to the acute care telemedicine. They're not delivering primary care. They are simply supporting chronic disease management and helping the clients get to the care that they need. And so that was a ratio that worked in the past in the past project. We also actually calculated out, how much time it would take for each of the different services, and we have a model where we have a hierarchy of services that we'll deliver based on ER use. So that was how we came to that ratio.
And the one nurse was split across the two sites.
Thank you for your time.
Thank you.